Hello, everybody, and welcome to Health, Wealth, and Relationships with
Tisa.
and Grant.
Welcome, welcome. Happy Thursday.
Happy Thursday.
Hey, so I'm excited about today. We have another special guest on today,
Yes, we do.
Dr. James Washington III
Yes.
out of Atlanta.
Yes.
James Washington III. He's currently self-employed, but he still collaborates with Morehouse School of Medicine.
That's right.
This man is awesome. He's a researcher. He's a minister. He's a jack of all trades. No, he's well versed and well rounded. And he has his own company called Community Development Enterprise for Innovation.
Let that sink in.
So we'll let him explain what all that means, and let's welcome him on.
Oh, we got to bring him up. How you doing, Dr. James?
I'm doing great today. Thanks for asking.
Thanks. You're welcome. Thanks for sitting with us today. We're going to unpack a lot of probably questions a lot of people have, but I already introduced you as a minister, a scientist, a man of medicine, and all of that good stuff. How would you describe yourself, Dr. James?
Well, I describe myself as a minister scientist because, once you're called, really, whether I was in engineering, whether I was in law, whatever the enterprise is or whatever the industry, I still think that ministry part never really leaves. But
Right.
the thing that really motivates me is that I see science as something that should improve the human condition, and I don't see that. So it's science that doesn't do that, doesn't increase the value of people, doesn't help a human need or respond to it. I'm just not with that anymore.
Right. And I'm glad that you have the blend of the two, because a lot of us are Christian by nature, but we don't understand that science part. Like, science is one of them things that I didn't never consider myself good in. He liked science as a kid, but it's kind of demystifying science, and science is just the study of something, and so. It naturally fits really within most things, but for sure, as a minister, as me, as just following my purpose, it all just kind of fits. So it makes sense. But I think you're here to help us really
Yes.
see how that all can mesh together, and how we can really, like you said, use science as a tool to better mankind, instead of just being used as a tool for statistics or a tool for a study or something like that, but actually something that's going to change the needle and move us forward to better health, to better whatever.
Totally agree.
Yeah.
So, Dr. James,
Mhm.
now this is what intrigued me about you and your background, is that from a health equity standpoint, and when we were talking right before the show, something that really kind of got my attention, that you were saying some of the the cause and effect of staying healthy or getting one of these diseases, or chronic disease or something like that. And you said social determinants are really one of the biggest factors from a statistical standpoint that you're finding. Talk to us about that.
Traditionally, we always study disease and disease pathology as, what's happening genetically? What's your medical history? What happened with your mama and your grandparents and so forth. Is there some defect or congenital condition that make you more predisposed to certain things? What's happened over the last decade, maybe it's a little more than a decade now, is that social determinants are a better predictor of what diseases we get. So things like racism, poverty, implicit bias. I mean, those things that when social determinants were first introduced, maybe a couple of decades ago, that's not real science. It's pseudoscience. It's it's the hard stuff with what's going on with you physiologically. But what we've begun to learn is that even our genetics are impacted by what's going on in our environment, which we now call epigenetic, or the term when we talk about phenotype rather than our genetics. It's really the things that our environment and culture or socially that help define how we behave and what goes on in our bodies.
Absolutely. And you can't deny that. Like you said, all research was just based on numbers and history, family history, and all that kind of stuff. My background is in social work and counseling, and so as a 14-year breast cancer survivor, you know, it's all about thank you, grace and mercy. It's really all about how we live. And so when Grant and I come on, we're trying to teach holistic living, mind, body, and spirit, because we're a total person, right? And so as we want to be doctors and only deal with the cancer in me, the rest of the social determinants led me to start Pink Lotus. We need support. We need to talk to each other as sisters. We need to be able to kind of dissect our own problems and come together and try to figure it out for ourselves. And so social groups and all of that stuff is much needed as I try to figure out why we're still dying 40+% more from any other culture. And it really comes back. Look, that's my catalyst of starting Pink Lotus. And so statistically, that has not changed. But what I've learned over my 14 years of survivorship, and it really is coming back down to the quality of care.
Yes.
And that's a social determinant, right? How we're treated when we go into the doctor, more so than the history, family history.
You know, it's ironic that you bring that up, because again, every disease, every class of symptoms, there are clinical guidelines for it. But yet, when it comes to patients our color, it's like, wait a minute, how come when we studied 1,000 cases, you all just didn't follow what the regular clinical guidelines are? Why did you deter from that? Why did you delay giving her this medication? Why did you delay being responsive? I mean, we see it all the time in the implicit bias.
Right.
And one of my concerns now is we haven't dealt fully with those implicit biases. So when we talk about, we're gonna have AI take over and it's gonna produce precision medicine and this and that. Wait a minute, whoa. Wait a minute. You first have to deal with the problems with our implicit bias.
Right.
Now teaching AI to do some deep learning and
right. And that's that part.
Yeah, right. Entrench those same things into what happens in the future.
Absolutely.
So I'm a big proponent of being cautious about that and being vigilant about critiquing what we're going to implement.
Yeah. And it's hard. Is it hard? I don't know, because I know AI is about how you program it, what information you give it, how you direct it to answer your questions. Yes. Are we going to have to do our due diligence in how we approach the AI and how we approach it in terms of you can't teach bias, right? You can't teach racism, but are we using the statistics of all of that to be able to educate the AI to make sure it's addressed? Is that how we have to do that?
Well, I'm trying to weigh in on that. And you bring up a good point. Both of you have just did, because data integrity is a big thing. So if if the AI itself is just an algorithm, it's a pattern, it's a software application. But if it's the source of its knowledge is what it's just taking from. So if you've got a history of implicit bias that is already in the data because that's the collected experience that has happened, all it's going to do is promote that continuously.
Okay.
So we have to be aware of that you're just going to make it worse instead of
just keep bringing it up and keep pointing at it without results. I need results. The information is for you to give me results.
Here's the example. This happened, right? So in Alabama, and I'll tell you, this is not in a health case, but it was in law, right? So they say, hey, we're going to use our AI to look at all our court cases. Well, a lot of the court cases that they had were back from the 60s to 70s during very biased area of time. Sure. Yeah. So now you're teaching the AI along those lines. So now when you bring a real case in 2026 before it, it's already, you're acting like you are a bigoted person is what this AI is acting like, because that's all the information that it has.
And from the era, it pulls from that era.
And it can't, it's not corrected. So we have to be aware of what the training of that AI? What was it on? Is it still promoting the same, biases that we all have experienced over time? And you're like, wow, we have this new technology, but we have the same thing. We're still getting the same results. What do you think about that, Dr. James?
There are two things that are problematic in what you're talking about in terms of data. All right. First of all, there's data underrepresentation. And that's happened with a lot of our drug development. Even now, a lot of those medications for diabetes, hypertension, whatever, when they tested it, they only, a single digit percentage of Black folks in it. Now, wait a minute. How are you going to have a single digit percentage of us in it, and you're going to overprescribe
it to us
those medications to us? So there's that underrepresentation problem. Now, with the criminal justice system, okay, let's look at how we've executed the law over the last, half a century or whatever.
Right.
It's you can't build your AI based on that data, because the blatant racism and other things were already built into it. So if it's just going to copy that, you're going to have much of the same results.
Right.
So AI almost has to, when you build the algorithm, you have to unlearn some patterns or try to pull those things out of the data. Maybe in this case, everything before the Civil Rights Act, or maybe everything 10 years after the Civil Rights Act can only be included. I mean, just those kind of, get rid of a lot of that blatant bias. Now, we know some of the implicit things are still in there, but even as we develop more of our own scientists who are going to be more ethical and more biased, because our culture is different, there are going to be some different nuances about it that's present in that artificial intelligence. And I think that's okay, because a lot of us, with our masters, doctorates, MDs, whatever, we've been trained on data sets that we're told, oh, yeah, this is the gold standard and this and this and this. And wait a minute. And now that we're more sophisticated about it, we're like, wait a minute, I trained on a biased data set. I recommend train on a biased data set. Yeah. So, we have to unlearn a whole bunch of things.
Absolutely.
Which is why when you said some disparities, wow, it's like when I go back to the 1990s, the same disparities are there. That's because the same biases and problems haven't been dealt with. Now, we've talked about them, but we still haven't done anything where we have addressed those different
things. Thank you. And that's where I'm at. It's like, that statistic for breast cancer has been out there since I got diagnosed in 2012, hasn't changed, hasn't gone down. And I feel like I'm on an island, the only one trying to do something about it. Because I'm like, this is a call for action. Like, why are we doing something? It was out before I got diagnosed in 2012. So my whole point was I have to do something to start bringing that statistic down. Physically, mentally, spiritually, do something to bring that number down. And that's why I'm not seeing. And I'm tired of quoting the statistic year after year. It is, it's sad. And it's just like, who's doing something about it? We're not getting any more clinical trials. What we need to do is get those clinical trials started on us, work with us to be a part of those clinical trials, because we don't want to do them. But just kind of, we have to flip the script on, like, how are we going to solve this problem if we don't be a part? We now need to be a part of those, not being scared of them, but so we can get some adequate data on us. That's the only way it's going to be done. We can't continue to go with 1% of us leading a study, and then they call themselves going to be for us. It doesn't work. It doesn't work. And so I'm trying to get something done. I'm trying to get a call to action so people pay attention, because it seems like they don't care that we're dying. And now that we've added,
they don't.
Oh my God.
And that's a sad reality. That's a sad reality. They don't. I can tell they don't, because I'm like, hello.
used to defend that, but I mean,
They don't.
ultimately, if they don't. But I think you bring up a great point with the clinical trials, and I also wanted to point out something with that is, all right, we have enough data because with AI we talk about, well, we need a lot of data and we need big data. Okay, we have a lot of
data's
data.
there.
We know what works well to bring more of us in the clinical trials, but those techniques aren't applied. That's why you see the same results. And I've seen studies where we collaborate with one of the other larger universities, and they don't use us to be the ones to implement the clinical trials. Look, all right, we know that, okay, clinical trials, no matter what the culture, what the people are, if it's that same ethnicity, they're going to be more receptive, number one. Number two, we found that sometimes you can train community health workers in that group, in that neighborhood, to be the ones to do the recruitment and ask questions. Everybody still doesn't do that. Why? Why don't they do it? I mean, they're
because it works. And that's the sad thing. You're talking about community health workers. Yep.
Yeah.
You're talking about navigators, community health workers. We'll have that money for a hot minute and it's gone. And we're in that same predicament now where I was trained as a navigator years ago. We had 2-year funding. We found out all the things that was going right. People were getting more involved because we need that buffer. We need that handhold person to bring us in and to walk us through the system, and to alleviate some of that fear. And now they went away, so we didn't have them for 2 years, and then so it's that soft funding. Now we got it back again with Douglas County Health, and she just told me she got 10 new navigators. But the problem with that is, are they going to be here for 2 years? They're going to be up to 5, which should make a difference, but that's an ongoing position. That's just like a nurse that we need to plug into the community, especially our community, because that's the person that's bringing you from A to B. That's the person that's bringing you from a health fair that we do screening in October, which we're going to do, to the Nebraska Medicines and to the Charles Drew institutions. That's what's needed.
Yes, totally agree.
You're right, and it's soft money, so nobody is saying that it's important enough to keep those people around. It's just like, we'll try it.
Let's look at it like this. And now we frame the problem. Definitely say, wow, there's a problem. But then you have the data to support that, okay, we do have some solutions that probably could work, but they're not implemented. Where is the accountability? Who is accountable? Is it healthcare of itself? Is it the provider? Is it the payer? Is it the patient? Where is the accountability? You're in academics. We're like, someone's like, okay, I see that there's a problem, but we're not implementing it because somebody is not accountable for it. Where's the accountability in your world? How as you see it, Dr. James?
Good question.
I've seen really what I call, we talked about the social determinants, but the political determinants have really imposed itself on healthcare in a way I haven't seen in my lifetime, where you have rules on doctors, you have rules on researchers, where even when they want to do it in the correct way that is best for the patient, morally right to them, you're having them do the opposite. Some of the rules around reproductive rights where, gosh, you have a woman who suffered a miscarriage, just needs a DNC. Oh, no, that's an abortion category. It's like,
that part, I see.
You will threaten a doctor's license in jail, and the person who put those rules together isn't even in health. You know nothing about what's involved, but you impose a policy not looking at any statistics or consulting experts on what the impact of that will be. I have a big problem with that. Even as we talk more about how important data is. Right now, data is in some categories more valuable than the actual money because it will drive policy. But we have a political environment now where you have states and parts of the federal government that aren't even paying attention to what the data is saying
Right.
and making policies and rules. And it's just so destructive.
And you're talking about the data. So I remember when we were going through the Navigator program, we were trying to get funding again. The data was showing that it needs to be a different type of care, right? It all comes back to that. And so the question is now, how do we address your quality of care, right? How do you address how the doctor talks to you? And so that's what the other nurse doctor that we had on the last time, he was just explaining how, you have to almost set a different precedence now when you go into the doctor's office. You have to be knowledgeable about your own care, but you also have to don't go in there as a wimpy patient. Go in there as somebody educated and want to know, and your own advocate. You're like, let's work together to help me, not just you tell me to take a pill and I sit here and go, okay, and I go with whatever you say and not be a part of your own healthcare. Once we start taking advantage of and being our own self-advocates, it'll start changing the landscape a little bit because they'll have to address us differently. But it starts there. But it also starts with training with the new nurses and the new staff. So we are with Nebraska Medicine here. And so at our health fairs, we are working with all of the new going to be nurses getting ready to graduate, whatever year they're in to graduate for nurses, so they can get to know the community, so they can get to know your Aunt June who haven't been to the doctor and she knows why, and all of that history, have empathy towards that history, know it. That's where it comes from, because they can't deny the statistics and the history behind our fear, and just kind of re-educate them at that stage, because we can't go back and teach these old white doctors nothing. They're not going to change their mindset, and they're not going to change their quality of care. We got to catch them coming hot off the press, is what I say, and start giving that cultural competency right off at the beginning. That's one way to do it, but it's how do you change? That's like saying change a racist person. That's like saying, you know what I'm saying? How do you change a racist person?
This is what I've learned in my 10 years now, studying healthcare, especially from a technology lens as well. When you start looking at the American Medical Association, and you start to say, well, why is there a National Medical Association? Well, that's the quote unquote diverse part of that. The AMA for a lot of years wouldn't even allow Black people to participate in the AMA. But you got to remember, so why is that important now? Because a lot of the benchmarks that were created of how they studied medicine was made during this period of time. So when you say, oh, they don't care, somebody says, oh, what do you mean we don't care? Well, the practice of itself has already is biased against other people that are not in how they create those benchmarks in the first place. So a lot of those were made on a white male subject. And that's how you get the medicines that were created. And if you don't fit within that parameter, I say he wants to talk because he knows what I'm talking about, right?
Yeah.
Yep, absolutely. And the other thing is not, when you said it, when you talked about not implementing things that are better and such as a navigation and community health workers, those should really be the new standard. That's it. That should be a position. On, they should be a part of every public healthcare
position. Yes.
It's like it's not. It shouldn't be grant funded. It shouldn't be something. Oh well, this is what 40% of the population does. No, that should be the mode of doing that. And then the other piece that you spoke to is, if you talk to the average doctor and nurse, they don't want to be a part of this value-added care system that says, oh, well, you have to see 1,000 million patients in one day and spend 6.2 minutes with them. I mean, they didn't get into the medicine for that, but that's a part of the rule that they have to deal with. We know, for example, if you do more education, gosh, it mitigates a multitude of things. If you're able to spend 30 minutes with the patient, really getting at the social things that are contributing to their physical symptoms, again, you can come up with a much better treatment protocol and even alleviate their fears because they felt listened to, not that
that part.
that part. Through. Like, we never will produce some articles, but I still don't see where these things are translating into how we practice medicine differently. So I'm
and you almost have to go back and reteach a doctor, don't you?
Yeah. Well, with the AI, of course, we're now having to integrate it in curriculum and trying to demonstrate how you can use it to challenge people rather than the concern about, they're just going to use AI to cheat on their exam. There are ways that we can use a technology like, let's say, virtual reality. Okay, you can create a course, and I can be standing inside a cell and look to my left and look to my right and see the mitochondria and see the other stuff. It's like, wow, now I get it all. Versus, some of this other stuff that we argue about. We have to think about how we can make things more integrative and how it'll engage our learners and our students.
Sure.
100% of what you said there, and this is my prediction that I would say, because you have now a powerful technology tool like we call artificial intelligence. What you're now is bridging, it sees our intelligence holistically, and it can begin to even look at it and say, you know what, this was wrong. We've been doing it this way, but it's actually a wrong process, wrong procedure. Here's a more precise way. Now, who's going to be accountable and say we need to now implement this change? So you get CMS. CMS is part of the government and things like that. Then look at the incentives and the compensations. All these things you start to say, wow, this is a bad model. Everyone in America, if you haven't been listening, I think it's like $2 trillion or so of money goes into our American economy to support the healthcare system that's broken. It's one of the worst healthcare systems in the entire planet because of the way that it's implemented. We have an opportunity to change it, but we've got to be accountable for that.
Among industrialized nations and the first world countries, we are typically either last or close to last.
We are.
We have the most advanced technology. We have the most medical schools and research centers and all that, but it doesn't translate into health of our whole population because we treat health like it's every other enterprise. You can't teach health. You can't treat health like you're buying automobiles, you're producing a product. It involves human beings. So really that not making healthcare a right, I think is a major problem. I mean, there are even communist countries like Cuba where healthcare is a right and they prioritize it and they get better results for the entire population than we do. And that makes no sense.
And what do you think that takes it back? I think because we are a country with a bad history, I think we are going to continue to be last because our country, as you know, is not ready to deal with our history. They're trying to erase our history, right? So if you're trying to erase something, that's again saying I'm not dealing with it, and that's I think why we're not moving the needle because we have such a racist background. That is speaking louder still today as it ever did, and until we address that's here, that the racism is guiding all of these problems, it's not going to be solved because they're going to keep doing like no, that ain't it. Nothing to see over here. Oh, it's not that. It's not that we're treating you guys bad. It's over here. Look over here. And it's not that we're not listening to you guys. It's y'all coming in too late. No. It's we come in too late. You're not listening to us. No, you're not getting the same recommendations. No, you're not teaching us anything that's going to help us help ourselves. So yes, we still feel like guinea pigs. We still feel like you're not listening. We still feel like we're just test tube babies. And that has not changed. And again, we have to get with these younger people to kind of show them a different way. My doctor is not going to go back and change the way he does healthcare. He's not. His mindset, he's 80 or 70. That's a done deal. But I can go in with a different me and challenge him to treat me better, right? I can say, I know this is going on, blah, 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 blah. And if he's not listening, say, I don't think he heard me. Or maybe get a new doctor, right? You know what I'm saying? But we have to really take whatever power we do have in that situation and activate it.
I think what
Yes.
you're talking about, and this is a trend that's happening now. You probably know this, Dr. James, is that a lot of people, especially people that have certain resources, they leave the U.S., go to other countries to get medical procedures done. Number one, it's going to be less expensive. Number two, it's probably going to be better care. That's something we should look at as a nation. Like, wow, why is our own population leaving to go somewhere else to get procedures done? Because there's a systemic problem, and it could be because of, to your point, the capitalism that is built into the healthcare system, and it is not a social construct, more or less, that it's made on a for-profit business.
Yes.
So
Ching,
compensation makes, drives behavior, right? To your point about a doctor, it's like, no, I get paid by seeing each, the more patients I see per day, the more I get paid.
Right.
So why am I not going to do that? So now you start seeing more concierge kind of medicine taking place, but those are for people that have the resources to pay for them.
Yes.
Of course, if you are of means, like, no, I'm not going to go to the public health system, so to speak. I'm going to go to this concierge system because I need somebody that really is going to take a look at my situation and give me the best possible care. These are things that are happening. There are new behaviors that are occurring in our system.
Yes. The thing is that the concierge concept isn't new, but it's like, look, every scientist, every researcher, every nurse, every doctor, every physical therapist, whatever you are in healthcare, you take an oath to do what's best for the patient and not to harm them.
Right. Do no harm. Right.
Well, yeah. Some version of that is in your oath. So it's like, why do folks have to pay extra to get us to do that?
Right. And is that oath even still in effect?
Who's litigating that? I don't know.
Is that the oath that they still take? Do no harm.
Oh yeah, absolutely. Oh yeah, everybody.
And
takes an oath.
so are doctors training to do no harm, and are they training to go in there with an empathetic listening ear, or are they told you got hundreds of patients, so you got 15 minutes, but both getting through it how you can?
It's hard to do both.
It's like, how is that train? It's hard to do both.
You make.
What's the training? I want to know the training, current training for a doctor.
Many doctors experience what we call moral injury because they don't feel good about having to make that choice of, just seeing this, just, getting them in and getting them out. Here, just give them a pill. And yeah, they don't like that. But in a system where, again, you have the have and the have nots. If you became a doctor, PhD, you're from a regular family, middle class, oh, you got 6 figures worth of debt. So you're trying to get that taken care of as much as possible. Whereas, you come from a different echelon and follow those footsteps. It's just different.
Yeah.
So there are financial pressures on them. And then you also mentioned Medicare and how reimbursement is done.
Yeah.
Oh gosh, the
They're making a
Medicare
nightmare.
was developed originally in the 60s. It hasn't changed radically since then. It should. And again, we have enough data so that we could change that system. It's still not a system that is centered on the patient. It's still centered on the financial incentives.
Right.
So that's why we don't get the optimal patient care because of that.
Right.
Let me give you some statistics on this. This should shock a lot of people. The 4th leading cause of death in the United States is the healthcare system itself.
That's funny. That's funny and not funny. Wait a minute. The 4th leading cause of death is the system?
Yeah.
Wow.
Yeah. Let me give, for instance, what I'm talking about. If you took 2 jumbo jet flying planes with about 300 passengers each, and they crashed, and everybody died every single day in the United States, that's the healthcare system. And if that happened, like I just explained, you would like, oh, we got to ground all the flights. We got to hey, what is going on? You got 2 jets crashing every single day. But this is happening. but it's happening in such instances that we don't see it as a whole.
Right.
I think by utilizing AI, you'll be able to see this, like, oh my God, all these medical errors because the incentives are not in the right place.
Right.
Right.
Yes. And the people who are making the policy aren't making decisions based on that. And again, what you made me think of when you gave that plane example is all over the country, not just here in Georgia or Atlanta, but I saw this when I was in Chicago too, and I know it's happening other places. You have hospitals closing, and you're having rural populations, and you're having poor to middle class populations stuck in areas where there's not even a doctor or office or hospital that's close to them. So they have a heart attack. They're gonna die in the ambulance because they gotta go 45
an
minutes
hour, right?
Man,
just to get there. Whereas if you live in an affluent neighborhood, oh my goodness, there's like
there in a minute.
Hospitals. Let me pick a direction to go, and within 5 miles of me or 3 miles of me, I can get to a hospital. We just do this too much, and we know better. We have the data to prescribe where we need to put hospitals and where we need physicians. And what do we do policy wise? We get on these schools are letting too much minority medical students in. That's what you're worried about?
Right.
Come on.
Yeah.
Total off focus.
Look at the priorities. That's
total
pathetic.
Yeah. And again, that just speaks to that history of just racism in America. It's like that's what you think of, and we're thinking about lives saved, and you're thinking about how many Black people's in there. It's like, hello, your priority is not where it should be
at all. At all.
And that's again, the racism speaks so loud.
Well, it's systemic. And when we say systemic, it's not just in the attitude, it's the system and how it's arranged and how it operates. And people are like, oh, well, there's something wrong with it. No, maybe that's exactly how it was prescribed to operate. And then until someone by design. So you're like, hey, well, who's going to be accountable to change it? That's why I go back to accountability. If you don't understand it, say, well, that system's not serving me. Well, maybe it was never intended to. So now you have to understand how I need to create an environment that that works for me. So that takes it back to the individual and the person with the community. Like, hey, this is our problem. Obviously, it's not theirs because they're not incentive to change it, right? So you got to think about these things.
I totally agree, and to that point, that's where I think we need to use our wealth to make those kind of investments. Okay, instead of waiting for another hospital, look, let's just get together, let's strategize, let's build our own hospitals, let's build our own clinics, and not waste our money on some Christian Louis Vuitton shoes and look at this chain I got, all that nonsense. In a place like Atlanta, there's more Black millionaires and billionaires here than anywhere else. Okay, let's put our investment together and build our community. We have enough to build our community here.
Right.
We can get to data that tells us how to do it right and optimally. But we still distracted by
priorities.
So we're working on that. Now, I do want to talk about in terms of solutions in the future, in that some of the things that we're teaching college students and grad students, when I get in front of youth audiences, if I can get to youth that are in elementary school and high school and expose them to these things early, I think they'll have an advantage in the future, because it's teaching them the programs and coding that work today. It isn't what they need. What they need is to be critical thinkers and problem solvers that can use whatever AI tool is available to them. Not just, I know everything about Claude. I know everything about Python. It's great that you know those. But how do you apply these technology tools to social problems, health problems, to building economically your communities. That's what the most valuable source is. And the reason the community can be effective in that as well is because you are an expert in your community. If I come in, I read some articles on it, I drive through. No. You are the expert. So if you know the problems, if we show you how to frame the problems and use AI to solve it, then we empower you because it's based on the knowledge that you have, not the knowledge that I bring.
Love it.
Yeah.
Thank you, Dr. James. I really want to thank you for being a guest on our show. This has been enlightening. I'm sure a lot of people have learned a lot. We want to understand, why would a business want to or HBCU want to engage with you and take advantage of the business that you have?
Okay, with community development enterprises for innovation, we would work with helping you integrate AI into your curriculum. And again, it's to, in this case, not just learn the technology, but learn how to utilize the technology so that you can do the higher thinking and innovation. The other thing that we have to be aware of is we have to empower people in a way that we utilize what they know. And again, I go back to that example of, you are the expert in your community, in your area. Okay, what problems do you want to solve? What problems do you want to address that your government isn't, that your state isn't? You have all the firsthand experience with that. Now, define those problems. Now let us come in and help you utilize AI to help you solve those problems in an expedited manner. That would be the benefit that we would add.
I like that. And you said you work with a lot of HBCUs. I like to hear that. And throughout, I know you've been working with Morehouse College for a number of different years. And I know there's a lot of people that have lots of need right now. How do you integrate AI to get the value that we need out of it, to change these things that we talked about that are these problems that are just persistent, that we can get past?
Now, my question to you guys, AI guys, can we build a program? Because my father was an old computer programmer back in the day.
Yes.
Can we build an AI program? So my vision is to open up my holistic house of healing. It's about a wellness plan, that kind of stuff. Can I build an AI program to help me develop my wellness center? I kind of know what I want in it, but in terms of bringing in the right staff, in terms of pitching it to the community, in terms of whatever. I know we need a wellness center. We don't have anything between the home and the doctor. I want to close that gap and say, let's meet you where you are. Let's set up a wellness plan. Like, what does your next year look like? You're currently pre-diabetic. How can we make it so you're not diabetic? What are we going to do between A and B to make that happen? So totally different from the healthcare system, because it's not a healthcare system. It's a stay bad, stay on whatever. It's not. So really use those words and build a wellness center, a wellness plan. And so I want to use AI
annuity plan for the pharmaceuticals and the drugstores.
Right. I don't know. It ain't healthcare. It ain't care. It's health non-care. I don't know what to call it. But I want to use AI to help build my wellness center and make it so, addressing all those social determinants, right? The fears, the this and the that. So they are coming in willingly, and they are taking a different whole proactive approach to their healing and health.
That's something actually near and dear to my heart, in going into the communities and talking to churches and small businesses about these things. And actually you have the beginnings of doing just that, because all right, you kind of know what you want. So it's a matter of laying out all those parameters, what the expected outcomes are, and then what we might do is plug in our artificial intelligence system to help us prioritize which one of these things work, or showing you how to simulate. Okay, if I mess with this, if I mess with that, then what? So you can play with the scenario.
Play with it.
But again, it's all predicated on information that you know and that you've researched and provided. So it's real world stuff. It's not,
Right.
I read an article, so my artificial intelligence algorithm does this, and it assumes that.
Right now.
Yeah. Whatever about that.
Right.
No, this is good intelligence. We're definitely going to tap you along those lines to bring you in as we build this out, as we go forward. We don't want to do these things as one and done. We want to continue to have these conversations as we go forward, because grassroots, this is a grassroots effort in what we do with health, wealth, and relationships. We talk about these things because at the end of the day, we're the one that were affected.
That's right.
And so we can create new systems that is going to work better for us. Then we need to do that without question. So Dr. James, I want to thank you again for being a guest on the show.
Thank you, Dr. James. We'll be in touch. And I'd say we do a follow-up show just to continue to talk about how we can solve some problems and how we can use AI to solve these problems. And maybe we'll have them drop some questions in our chat.
We
or
might even have a
comment
panel group. We bring all our past speakers together.
Oh, yeah.
And really kind of just sit down with these things as we continue to move this needle forward. And you're going to be definitely a big part of this. And I love the work you're doing with the HBCUs. That's awesome.
I love the work you're doing as a minister, just as a Black man wanting to bring all those pieces together. That's where I'm at. It's just like,
don't dismiss me coming out there where you are and us, doing a half a day of something or
absolutely. And us coming there. Where you at?
Atlanta.
I go to Atlanta, so we're gonna keep this party going because I think it's a good relationship. I think we have we're synergy in terms of like our thinking and really have the same similar common goal. We just want us to be more healthy, more informed, and just more.
So we collaborate, we work together. So thanks a lot again, Dr. James.
Okay. Be in touch.
All right.
Thank you.
Wow, he was fantastic.
He's good. Oh, we got to keep in touch with all these brothers.
We got to get everybody going.
Everybody out of Omaha. Let's just get these people together.
Before we let it go, we got to make sure you guys know what's got coming up, because we've got October 3rd, I think, with a little something's going to take place. Right?
October 3rd, we have our 8th annual Pink Pancake Feed for Pink Lotus Project Nebraska. It's a Pink Pancake Feed and health fair. So come out to Mandela Elementary on North 30th Street from 9 to noon. We're serving pink pancakes. You get 2 turkey sausages and a drink. But the main thing is I want you to bring your families out and get your health screening. Exactly. If you haven't been to the doctor in the last 6 months, come out and get to know your numbers. We always have a knowing your numbers. We got diabetes check, cholesterol checks, all of the things you need to know your numbers on. We'll have them there. We even have Charles Drew out to set you up with a primary care physician. If you don't have a primary care physician, we'll have navigators available. From Douglas County Health. We'll do partnership. And Pink Lotus, I just want to give just a shout out to Douglas County Health, to Charles Drew, to Nebraska Medicine for partnering with Pink Lotus to just CHI, yes, to spread the word, to just get more proactive about our health, to just help us be healthier people. So shout out to all those guys for willing to be partners with us. And so all those people will be in the building on October 3rd. Come out, have some pancakes, support the cause, but get some free screening. Bring the entire family. We have clowns, we have music. It's going to be a whole health fair event.
I love it.
Mandela, October 3rd.
Pink Lotus Project Nebraska.org. That's where
PinkLotusProject.org. Get your tickets, or you can scan the QR code on the flyers. The flyers are out there. Tickets are available already now.
I love it. And I have my own Omaha AI Marketing Accelerator. Make sure you sign up for this. Right now, I'm partnered with Omaha 100. This is a $2,500 value that we're giving away seats to primary businesses in the Omaha community. You can sign up now. The cutoff is August 14th. So go to my website, 5starbdm.com. Just scroll down a little bit. You'll see the accelerator. Click on that. Get to the wait list. Get your name in there. Put your name in the hat. This is going to be ongoing. So it's not going to be one and done, but it'll be ongoing for the next couple of years. But we have to get our community set for this new AI age, and this is exactly what I'm doing in 5-Star BDM.
Right. So he's going to help get that all that vision we just talked about with the doctor. We're going to use that
We're gonna do
AI
that.
for good.
For good.
Don't be scared of it.
Don't be scared.
Don't be scared.
All right.
See you next
Peace
time.
out. Next time.
Imagine waking up with more energy, a peaceful mind, and relationships that grow stronger every day. That is the vision Tisa Harden and Grant McGaw want to help you achieve, and it all starts with simple, practical steps you can take this week. On health, wealth, and relationships, every episode brings you real stories and trusted experts. Tisa and Grant focus on 3 tactical steps each week. Small, doable moves that protect your health, grow your savings, and bring you closer to the people you love. No complicated rules, just real progress. Try a clinic-to-kitchen swap to boost your energy. Start a money buffer habit that quietly builds your financial confidence. Or try a 1-minute exercise that helps you reconnect with your partner. These quick wins are not chores. They are steps toward a better life. People who try just one intentional step report more energy, less money stress, and evenings full of laughter again. Join Tisa and Grant. Start small, live bigger. Tune in every Thursday at 10 a.m. on Facebook, LinkedIn, and YouTube, and subscribe.